So it's really a pleasure to welcome you to Massy. We are working on a case which I think you will it will be interesting for the discussion and for the technical approach. So Thomas Ovas will be the first operator. I will be there just to comment the procedure, explain or answer to the question that you may have. We have also Sarah as a nurse and Sophie outside who will give the material. So maybe you can start with the story of the patient.
Okay.
Yeah, so it's a young patient, 50 years old, who came with angina to our hospital. Next. He had a lot of risk factors, hypertension, hypercholesterolemia. He was a previous smoker, and he had a story of anterior MI in 2017. At that time, he had the PCI of the LAD with 2 overlapping drug-eluting stents and kissing balloon between LAD and diagonal. He had also a CTO of the mid-RCA, which was not treated, and the patient was asymptomatic for 4 years. Then he came back in June this year for angina, and MRI showed non-transmural anterior MI.
And it is anterior ischemia on MRI also, and not inferior. I think there is a small...
And he had inferior ischemia on MRI and a small ischemia in the anterior territory. The right coronary artery was treated. Then the patient was again asymptomatic. Next slide. So this is the angiogram, because the patient came back for again angina.
Yeah.
And so this is the angiogram of the left coronary system, and you can see that there is a intermediate lesion in this view of the ostial LAD. You can see also the stent, which was not coming up to the ostium of the left main. So there is few millimeters between the distal left main and the LAD. Next one. This is a cranial view. You show again that this. Can we go back? Yeah. Go back again. Go back. Okay. Next. Okay. So this is a cranial view. You can see again this lesion of the ostium of the LAD. Next. This is a right coronary artery. And you see the initial lesion 6 months before of the right, which was treated. I will not show you the CTO, but it was a good result. Next one. So 5 months later, after the disobstruction of the right, there was angina again, class 2. And the MRI was done again with the mid and apical anterior wall ischemia. Next one. So again, this is the result of the right. So you can see that it was a good result. Next one. This is again the left main LAD. You can see it looks very similar to what we had 5 months before. Next one. This is a spider view. You can see in spider that the ostium of the LAD looks diseased. Next one. This is a cranial view. Again, it seems that there is some progression of the disease at the ostium of the LAD. And next. And FFR was done, which shows a FFR of 0.77. So clearly, there is now ischemia in the anterior territory, which was also shown by MRI. Next one. So this is a summary of the case. So a young patient with multiple risk factors, previous anterior MI with no important sequelae in the anterior territory, previous CTO of the right coronary artery and progression of left main LAD disease. So maybe Thomas, we can show the first acquisition that we have done. So we are going through the radial.
Yeah, we are in a right radial approach. We discussed with Thierry, and as we perform sometime with large left main and large arteries, it's sometimes a very good option to go with a 7 French guiding catheter. So we are in a 7 French with an extra backup to have a good support.
Régie, can you show the setup on the table? Yeah. So this is a 7 French extra backup
375.
375 guiding catheter. And of course, we are through the radial.
So we can go back to the angio now.
Yeah.
Thank you. Yes.
Yes. Can you hear me?
Yes.
Yeah, of course.
Okay, I have a great panelist with me, so let me introduce the panelist and then maybe take their opinions about the case.
Okay,
and
perfect.
Then after you will tell us your strategy.
Of course.
So I have with me Dr. Horst Sevet from Germany, Dr. Mohammed Belghaith from Saudi Arabia, Dr. Fahad Basley from UAE, and Dr. Hussam Noor from Bahrain. So if I ask the panelists, each of you, if you've seen the case, you've seen the scenario, so who's going to start? Up to you. Tell us, how would you approach such case? Dr. Horst?
Well, I'm not a friend of radial, I must admit, so I would do it by a femoral route, but that's not important here, of course. What I would like to see is a shot where I can see the ostium of the circumflex, because that was not clear to me whether there was a stenosis or not. Maybe you will show this later on. This will depend upon the strategy. It looks here that the circumflex ostium is free, right?
Yeah. And we have seen also on, so we have done OFDI just before being live, and we have seen that the ostium of the circ is okay, but there is disease of the ostium of the LAD and also distal left main.
So in,
and you can see,
so that if that is clear that the distal left main is involved, which is, well,
yeah,
not good to see from here, then obviously I would place a stent from the left main to the LAD, but probably not, I would not attempt the circumflex in this case.
Okay, Mohammed?
So your Horst, it's a great comment. Do you plan to do just a crossover stenting, or will you open the strut toward the circ?
Will hear from the panelist, and then we'll discuss about the proper strategy. Okay.
I will obviously place a wire into the circumflex as well, but I will do a crossover stenting and probably go ahead and dilate the ostium of the circumflex afterwards, but maybe not.
Okay.
I think I will agree that the ostium of the circumflex artery, it looks big and large, although in some of the views we cannot see it very well. There is some little progression, I agree with the previous cut, in the ostial LAD, and even the distal left main, it's hazy today. It's not that narrow, it's not that stenosed, but it is disease. And I think intravascular imaging or intracoronary imaging, either IVUS or OCT, will be very helpful in this case. But 100% the circumflex should be wired, and we might not end by doing anything on this large circ.
Okay. Any other thing to add, Fahad?
I think it's a great case. Definitely this patient is symptomatic. We have an MRI which is positive for ischemia in the LAD territory, also positive FFR. I think that distal left main and ostial LAD needs to be intervened on, and I prefer to go for a provisional strategy for now, as the left circumflex, at least the ostium is healthy.
Okay, Terry, is the RCA, is it fixed or not yet?
Yeah, it's fixed. Yeah. The distal right was, the mid right was treated 5 months before.
Okay.
And the patient was then.
Sorry, go ahead.
So what's your strategy now?
Wait, Terry, what is FFR and circumflex?
So we have not done FFR on the circ, only on the on the LAD, which was 0.77. We think that probably FFR will be not significant in the circ, but maybe not, because as you said during this discussion, the distal left main looks really diseased. There is a gray zone just at the distal part of the left main, so maybe it will be significant. But we will follow your advice, and we plan to do that. So provisional side branch stenting approach, stenting first from left main to LAD with 2 wires in place, then doing a proximal optimization technique. As you see, the left main looks very small as compared to the circ, and kissing at the end. And
You've
probably
done
will
imaging,
not.
right?
Yes, we will show it to you in a few.
So what we can do now is to show you the OFDI. Sophie, so we'll show you the pullback that we have done. Est-ce qu'on peut montrer le OFDI? Yeah, okay. So we can go from the, so this is LAD, which was stented in 2017. Go slowly, yeah. You can see now that there is some restenosis, but not very severe. Okay, continue. And the disease will increase proximally at the level of the ostium of the LAD. There is also some calcification. Okay, continue. Yeah, so this is close to the ostium of the LAD now, yeah. Okay, and now we are at the level of the bifurcation with the circ. You can see the big nodule, eccentric nodule on the distal left main. Continue. Continue. Yeah. And now we are, you see, there is disease in the left main, clearly.
Sherry, I think everybody agrees that there's disease, but does that
Yeah.
mean it needs a stent? I mean, if FFR and the circumflex would be normal, then you could consider to just treat the LAD.
Yeah, absolutely. So the plan is to do provisional, so stent from left main to LAD and open the strut toward the circ because it's a big circ with 2 important marginal branches.
And I and I think considering that the plaque is going from the left main to
Est-ce qu'on
the
peut
LAD,
montrer à nouveau l'angio,
it
s'il vous
will be
plaît?
very hard to put a stent right at the ostium of the LAD and have a good result on this bifurcation. You know, even if the angulation between LAD and circ is okay, you see the view shown that it will be hard, as you can see here, to put a stent only on the ostium of the LAD.
Yeah, of course.
It's really risky, and if the stent is misplaced too far, you will not cover the ostium. If the stent is too proximal, you will be in the distal part of the left main, and you will make the angioplasty will become very complex.
Yeah.
So what's the measurements you get from the IVUS? Like for the proximal LAD and for the left main, what's the measurement?
The proximal LAD was 2.4 and the left main is 3.6. But I think it's not the right size for sure. If we respect the fractal law, the LAD is it's about 3 and the circ is about 3.54. So at the end, the left main will be at least 4.5 or even more 5 millimeter. So now Thomas is wiring the circ. So we have Tution Blue, the favorite of Thomas. So and now we'll predilate the distal left main and ostial LAD, and we have decided to use a Shockwave balloon because of calcification, in order to have a good expansion of the stent at the end in this young patient of 50 years.
So maybe we can share a few tips with the audience, if you agree. So I think, so the 7 French was one first tip. The second tip is when you will wire the LED, you can make like here a measurement to see the length of the left main and the proximal LED, which was about 30 millimeters or a few millimeters, maybe 28 in this case. Then general rules for bifurcation, you will try to put the wire as distal as you can to have a good support and to avoid movement of the wire during all the procedure. When you treat the left main, I think a good rule also is to let the main wire all along the case in the LED and not to perform exchange.
Yeah. So we'll use 3 wires during the procedure. So we have prepared a 3.5 Shockwave balloon. So one very important tip and trick is it's very important to have an optimal preparation of the balloon with no air, because if we have air, the Shockwave technology will not work. So we use a huge preparation to be sure that there is no air in the balloon.
Jerry, I saw the calcium on the IVUS, but not really on the fluoro. So do you always use Shockwave in this situation?
Yeah. In fact, you maybe can we show again the spider view? You will see in the spider view the calcium. In fact,
Here, okay, you can see a line of calcium just at the end of the left main on the upper part.
And what we can do, we'll do a stent enhancement, Thomas, to show the calcification of the distal left main.
Let me ask Arif. Arif, you have good experience with Shockwave.
Yes, Mohammed, I think we have visualized some kind of calcification, eccentric calcium at the distal left main, and Shockwave might be appropriate to prepare for an excellent expansion of the vessel. I mean, I wouldn't say it's a must, but it can be helpful in this case. So I couldn't see much of calcium in the IVUS. But from angiographic, yes, I could realize that there is a little bit chunk of calcium at the upper roof.
Would it be an option to do the stenting first, and then if the stent is not fully inflated, then to use Shockwave?
No, actually, that's not the recommended situation for the Shockwave. I mean, if you want from the upfront, you have to go with the Shockwave, because then there is a chance of damaging the polymer. And that's something they are avoiding using the Shockwave.
I think the real algorithm in the brain, in our mind, is what is your threshold of using all these devices? What is your threshold of using Shockwave in a situation like this? I think we know there is calcium, but where is your threshold? I mean, not everybody has Shockwave, but everybody could have non-compliant balloon. If almost everybody has a cutting balloon, when do you decide this versus that? I mean, what I would do is, like we had the talk by Akiko yesterday, is I actually calculate the calcium volume index, and based on the calcium volume index, I decide which modality I'm going to use. So in this, I don't think the calcium volume index is less than that. I would have gone with a cutting balloon, a non-compliant balloon, see if I could crack it up, and if not, then I may escalate it to a Shockwave.
Un petit peu plus proximal. Ouais.
So tell me, this is the first pulse you gave?
Yeah, so we have done a first pass with 10 waves, and now we move a little bit, and we'll do it again.
Do you tend to give the whole cycles, all the cycles?
Not always. Okay. Not always. It depends on the expansion of the balloon. If we have a good expansion, we'll not use every possibilities. So we can go up to 80. You see there is still a waste on the balloon. So you can hear probably the shock. So we can do 10. 8 times. 6.
Terry, can you change the angulation so that we could see in the different views, please?
Yeah, of course.
Thanks.
Okay. So maybe we can move a little bit more again.
Terry, will be nice if we have just to show how you use the Shockwave, because some of the people in the audience, they don't have any experience with Shockwave.
Yeah, so that I said it's very important to have no air in the balloon because if there is air, it will not be effective. You see in this view that we have no residual waste. Then you go to 4 atmospheres. Si on peut montrer en régie. This is okay. And then after the pulses, we can go to 5 or 6. We move because there is only one, the middle part of the balloon will be effective, so we have to move. Test. Okay,
I have a question not related to the procedure, but to your technique when you do fluoro. What is your frame rate?
Yeah. 7.5.
Because it looks very slow here, so it's the transmission, it's not your equipment. Okay.
Okay.
So the balloon seems now.
Yeah, and you see the calcification on the in this view. I think we can leave the balloon and make another stent.
Yeah, I think the calcium. You
Stent
can
boost.
the calcium.
Okay, so you can
imaging
see
is a must in this case. I mean, when you try to use Shockwave, is it a must-have imaging?
Oh, no, no.
You do a Shockwave without imaging.
I think
It's an open question. Everyone.
I think first the anatomy.
this
I mean,
way.
if you're doing distal left main imaging,
Okay, you
is
can you see
required,
the
just to see
can
the
you see the
sizes, to
extra-
see the the side branch of orifice, and also as you found here that
Right.
sometimes you see calcium that you didn't notice very well during angio.
Can you see the eccentric calcification? En régie, est-ce qu'on peut montrer l'image de stent boost?
If we show the stent boost, that showed it very
Yeah.
clearly.
Oops. Yeah, you can see it clearly. So it's a big
That's right.
chunk of calcium. Okay. So the next step.
Initially, because of the previous stents, we thought this is just the extension of the stents, but now we see it very well.
Yeah, and you see that in fact you have the stent at the proximal LAD missing 3 or 4 millimeters of the ostium of the LAD, and then this big a chunk of calcium. Maybe you can do an angio like that, Thomas, just to show.
So do you
the
go with
result.
a
Okay.
non-compliant balloon after to see?
No, we because now we have really no waste on the balloon at 5 atmosphere, so I think it's a good expansion. And you see, now we have completely modified the appearance of the distal left main. So I think it's very nice. Okay, so the next step is to stent. In fact,
Yeah.
so Thomas, which kind of stent?
It was a good comment from the panel that if you still have some waste, or if you think that the lesion is not well prepared, it's really important to complete the Shockwave with a non-compliant balloon.
I fully agree.
So I think a good message also is when we use Shockwave, we will use a balloon that it's a little bit bigger than the artery we want to treat, and we stay at low atmosphere. And when we use a non-compliant balloon, we will undersize a little bit the non-compliant balloon, or at most 1:1, and go to very high atmosphere.
Yeah, absolutely. Absolutely. In this case, you have seen that the balloon was fully expanded at 5 atmosphere. So I think for us, it's a good sign that we have cracked the calcium, and then deploying the stent will be easy with a good deployment. So Thomas, which kind of stent you will select in this particular case?
I propose, if you agree, to use a Megatron 3.5 because of the distal part of the bifurcation, the main distal branch, which is something between 3 and 3.2, I think. So maybe a small release of 3.5 stent should be okay.
At low pressure.
Yeah.
And
It will permit us then to have a good apposition on the left main. So it's very important to see, on the very powerful message, to say that even if the distal part of the vessel you want to stent is a small, don't hesitate to take a bigger stent and release it with a small inflation.
Yeah.
Because if we put a 2.5 stent in the proximal LAD, it will not be capable to expand enough in the left main.
35, 28.
28, s'il te plaît. Yeah, yeah.
Terry, can you tell us about the IVUS? What did you get for the ostial LAD, the size? And that might help us for the stent size as well.
Yeah, so the size
something like 2.93 millimeters.
Yeah. So in fact, it's very important to have in mind that the 3.0 stent is not the same design as the 3.5, whatever the company. So in this particular case, even if the LAD is 3.0, we'll use a 3.5 at low pressure just to be sure that when we optimize the proximal part in the left main, which is 4.5 or 5, we'll have a good scaffolding of the left main.
So you're going to choose 3.5?
So 3.5, 28, which is a lane that was measured by the wire at the beginning and also by OFDI.
So you're going to go inside the previous stent?
I think we will just be bore à bore, I think.
Maybe there will be an overlapping of 2
maybe,
or 3 millimeters.
Yeah, we will see, but 28, I think, is a good length.
Are you planning to go back to the ostium of the left main in this case?
Yeah, that's a very interesting question.
I think we have the feeling that the ostium is okay, and it was the case by OFDI also. So we don't need to be up to the ostium. What is important is so maybe we can do again the stent boost just to check the position.
Why not a very short stent? I mean, there's already a stent in the LAD.
See, it's yeah. So you can
maybe remove a little bit the guiding catheter, then pull back the stent
and see where we are on the with stent boosts.
Okay, I think we are overlapping here for 4 or 5
Yeah,
millimeters.
I think we will be able to pull back. So you see, we have 5 millimeter
overlapping
overlap, so you can pull back, I think.
So
you can use. Est-ce qu'on peut montrer le stent boost, s'il vous plaît, en régie? Okay, so you see with stent boost that we have an overlap of 5 or 6 millimeter. So we can pull back a little bit more.
Alors,
guiding.
Un petit test.
Toujours.
It's maybe better. I will do another stent boost here.
Non, tu vois, tu as encore 4 ou 5 millimètres.
Yeah.
Je pense que tu peux reculer. So we'll pull back a little bit more in order to have good scaffolding of the left main and also now too much.
We have a frozen image. What's happened?
OK. Ah, en régie, on peut montrer
On va faire un stent boost ici.
L'image. OK.
Yeah.
Ah. OK. On n'est pas centré pour le stent. On va le refaire parce que là, on ne le voit pas. So now it looks
Distally, you have room. I mean, just proximally, where is your landing?
On va faire un petit test, Sarah, s'il te plaît. I think we need some overlap because on the IVUS there was some plaque on the proximal part of the stent, and if we put the stent just if we try only a junction between the two stents, the result will not be nice on the proximal LAD. So I think we need a few millimeters overlap.
Okay.
Okay, let's do an angio like this, if you agree.
Good. So now we have 3 or 4 millimeters of overlap. I think it's nice.
Yes.
And we have a good scaffolding, not up to the ostium, but I think it's enough because the ostium is free of disease. So I think it's a good position.
So the advantage to cover
the panelists?
I think it's protruding into the aorta.
I think
no,
it's covering the
no,
ostium.
it's not protruding. No, it's not covering the ostium.
Maybe.
So we think it's okay here.
Okay.
Yeah, for me it's okay.
I think
if we look
for us it is okay because we could see it at the cusp there, in the cranial view.
Yeah, so I think to see where the relationship between the aorta and the ostium of the left main, only cranial view is okay. And so we look at this one, or maybe some LAO. Yeah, okay. Vas-y. Yeah, and you see that maybe you can push 1 or 2 millimeters if you want to.
You have overlap?
Yes.
Yeah, we have a small overlap. Okay.
Overlap, not too much.
It's enough. Test. Yeah, okay. For me, it's perfect.
Okay.
You agree?
Okay.
Yeah. Okay, so we'll deploy the stent at low pressure.
Maybe 6 atmosphere, something like that.
So this is, what size stent this is one more time, please? What size is it?
3.5.
So 3.5, 28.
Megatron.
Well, you see at 8 atmosphere, we have a nice deployment of the stent, thanks to good preparation. We do long inflation just to be sure that the stent will be fully deployed. And of course, after that, we'll have a lot of work to do.
Okay, so it's quite well tolerated on the pressure, but it's going slowly down and down now. Okay, so we can. So as you can see, as you saw, Thierry tried to make a long inflation in order to have a good apposition.
So now what is very important at this time is to avoid longitudinal compression of the stent. So Thomas will take care of the left hand control when pulling back the balloon, because if you pull back too quickly or you don't take care of the guiding catheter, then the guiding catheter will advance, and then you have one wire in the stent and one wire outside. So you will do a compression of the ostium of the stent. So this is very important point. And we learned from Excel study that when you have longitudinal compression, you double the risk of MACE at 3 years.
Okay, so maybe we can perform the pot now, Thierry.
Yeah, absolutely.
What do you think? Maybe we can ask the panel about the size of the balloon they'll use in this case.
Can you do a simulation just to see the circumflex now?
Sure.
Yeah.
So I will not engage more my guiding catheter. So
the quality will not be optimal, but it's okay. Okay. So now we have good result at the ostium of the LAD. Of course, at the end, we'll do kissing bone inflation.
And it's very interesting. You see in this case that the malapposition in the left main is really huge. You can't let something like that. So a simple crossover is a catastrophic result. Even if.
Let me ask the panelist here what they will do at this point, Dr. Horst. So he went up to 8 atmosphere, I think, on the stent.
I mean, at this point, you have to dilate all the proximal stent in the left main, and probably 4.5 millimeter would be fine. Maybe 5.
Okay. Yeah.
But I would have used a shorter
Okay.
stent just to treat that diseased part of the left main, and then we would not have this problem to think about a position of the stent here. But,
Yeah.
you know,
So this is the strategy of provisional. So you stent the vessel according to the distal reference, and then you do proximal optimization technique just to oppose the stent proximally and facilitate access toward the circ. So I think 5.0.
Yeah.
Well, yes. So we use a 5.0 non-compliant balloon. So we'll be able to go to high pressure now in the proximal part in the left main, just proximal to the bifurcation between LAD and circ.
This type of a stent, I think 4.5 to 5 balloon will be good, and you will have more expansion with such design of this Megatron, especially in the left main, I think. But the only thing, you don't want to go too much because that proximal circ is ectatic. It's not the real diameter.
I fully agree.
I fully agree also, yeah.
So we'll, of course, we will, in this case, we'll not do just a simple crossover because the circ is a very big vessel, but just open the strut toward the side branch or the circ with a kissing balloon. But
Okay, so I need a little bit more support. So very careful not to go against the.
Is it the good wire?
I will check. No. Okay, I think we are not on the good wire, so I will check the 2-wire position to be sure, because it's in this case it's not normal that the balloon didn't went easily in the. So yes, this is the LED, and that's why the balloon was not going easily in the stent.
If I may just share my thoughts, when you have significant, the proximal portion of the stent not expanded because, you know, we want to do pod, I try to go with a compliant balloon for a couple of reasons. Is one, you could also damage the stent going in with a non-compliant balloon, bulky balloon 5.5 or 6. You can damage it. So I use a compliant balloon to get in, and then also when you pull it back, it minimize the risk of longitudinal stent deformation. I don't know what other thoughts of the other panelists and my colleagues here.
I think we can.
That's an option if you have some kind of resistance of crossing. But usually, my standard, I go directly with a non-compliant balloon, but with just good alignment with the guiding catheter. Be careful. We face that kind of challenge sometimes. I agree with you. So I have to convert to a semi-compliant balloon to facilitate my delivery of the non-compliant later on.
Yeah, but absolutely. In this particular,
sometimes so sticky the fire and this, and you may have really problem by putting back the balloon. It might be a little bit problematic sometimes, and you have to be very careful and give your time for deflation, because that is another story. By part balloon non-compliant, if you are rushing by pulling back the balloon, it may get stuck at the tip of the guiding catheter, and that can be really nasty thing. Thank you.
Terry, tell us what you did here.
Yeah, so we have a non-compliant balloon 5.0. I think in this particular case, we can use both non-compliant or semi-compliant. So you see now we have a big size of the distal left main, but of course the proximal part is not expanded. So now we'll do a second inflation. Okay, so 14. Okay, good. And we can do a stent G's again, stent boost just to check, but I think it will be nice. I think both are okay, non-compliant, semi-compliant, but if there is any difficulty, semi-compliant will be easier, of course.
But both influence
maybe
were
we
in
can
left
remove
main
a little
itself.
bit
I
the
mean,
balloon
the
again.
calcium was at the ostium of the LED, right?
Distal left main and ostium of the LED. Yes, both.
So maybe 5.0 will be big for the ostium LED.
No, we don't go up to the ostium of the LED. We just go
We just
at
went
the
up to the
polygon of
camera,
confluence.
up to the carena only.
Okay.
Okay. On va refaire le stent.
So we'll do again the stent enhancement. Okay, so now it's nice. We have a full deployment of the stents.
Yes.
And you see the two sides, so the left main and the LED. Of course, it's not the same. It's exactly what we want. So again, Thomas, take care of not doing a longitudinal compression of the stent.
Yes.
And now we'll use.
Can we see the last stent boost?
Yeah, on peut montrer le stent boost, s'il vous plaît, en régie. Big screen, yeah, okay. Okay, so you see the two wires, LED, circ, the stent fully deployed in the left main, and then the second size, which is the size of the proximal LED. So 3.2, something like that, because we go to low pressure. But anyway, at the end, we'll do kissing balloon inflation with maybe a 4.0 in the circ, Thomas.
Yes, I think
and 3.0 in the LED.
If you have imaging on the table, do you rely on stent boost or?
Yeah,
we are lucky. Most of the well-equipped cath lab we have stent boost, and it's very fast. But if you wanted to make sure about the opposition of the stent, and you want to be like real, you want to confirm that you did a great job. I think intravascular ultrasound will be again fast, and you will have a good.
Yeah, I think as we use already the OFDI, it will be a shame not to use it.
So you see, Thomas, take care to go in a distal strut, which is a rule for provisional approach. I do an angio, so it's maybe more proximal than distal. Huh?
Yeah. So maybe we'll try to go back in the LED.
And the technique is to do a pullback from LED to circ.
So Terry, let me ask you, do you open the struts for the side branch when you do provisional?
Okay, this is very good. Yes, for the left main, we always do that. So now you are more distal. I think it's nice. Huh? You see the gel wire is in the lower part.
Yes, we can.
And the new wire is more distal. So I think it's a good positioning. Okay.
So you think it's a must to open up these struts in such a big vessel?
Yes, we think so. Of course, there is no proof of that. It's still a lot of discussion at the bifurcation club, at the European Bifurcation Club. But we have now cases from friends showing a colonization of the strut by a neoendothelium when you do not open the strut, and sometimes occlusion of the sock, just not due to restenosis, but due to colonization of the strut by a neoendothelium. So now Thomas is pulling back the gel wire, again, taking care of not damaging the ostium of the left main. And now we have a good positioning. So two wires, one in the circ through the stent strut, one in the LED, and we can do kissing balloon inflation.
So let me ask a panelist, who will always open the struts to the side branch, finish with a kissing balloon? Arif?
I don't do it anymore routinely. I have my own cases, and I don't see a reason if I have really good struts, large vessel, and this kind of lumen available. I don't have anything, as Dr. Lefebvre said, there's no data confirming that there is any long-term benefits or advantages in this. It might be good for a smaller vessel size to keep an axis for the future, maybe easier. But for such a large vessel size,
we're talking about left main. Left main, if you're doing left main LED, You
Yes, I
open,
just leave it there, and then if the flow is fine, and I have no
so
problem.
you don't open the struts to the circ if it's,
Unless I have a
Combien?
compromised
Sarah, s'il te plaît.
On met le 4
ostium,
d'abord.
that's the only condition where I do a gentle ballooning kissing to create kind of alignment of the cranial. That's
Okay.
all. But usually I don't do it
Vas-y,
routinely
injecte.
anymore.
Good. Okay.
Okay.
So we have already.
I never do it, and I've never seen a problem. So
Yeah.
But I mean, occasionally there are problems when you dilate the struts, so you have to counterbalance.
Okay, so you can see that we have already a good
I don't
result.
open the strut unless I need to.
Yes, just to show the initial result, which looks very good. But in our opinion, it's not enough, because if we have to come back to treat the circ in 5 years or 10 years, having a strut which is not open, maybe colonized by struts.
It's a young patient.
Yeah.
I think the progression of the atheroma during the last few years was quite important.
And of course, there is also a lot of non-clinical data showing that if you do not open the strut, you have areas of low shear stress opposite to the carena, which will promote atheroma. And so we think that for the long term or the midterm, it's even better. But of course, there is no proof of that. So just because for us, it's in big vessels, it's a routine to do kissing bone inflation. So we use a non-compliant balloon in order to avoid.
Okay, maybe I will go in the LAD with the other balloon to increase the support.
So it's a 4.0 for the circ and a 3.5 for the LAD.
Fahad? So in your practice?
No, I don't do it routinely unless the side branch or the circ is compromised. Otherwise, I wouldn't do it routinely. And but we respect the decision of the operator as well.
Okay.
And in this particular case, I don't know what do you think, but I think the view of the bifurcation and the position of the carena, there is no perfect view.
Absolutely.
So
we don't know. Maybe there is a tight stenosis at the ostium. We don't know. Just because of carena shifting. Inflate the LED, Thomas? Or
no? Je vais essayer. So I'll try to go down with the circumflex wire to increase the support. You can see that the balloon in the circ won't go now. Or we can
do an anchoring if you want. So you see a big angulation between the left main and circ.
So maybe we can do an anchoring in the LAD with a very small pressure.
Yeah.
Okay.
Okay.
So let's see if it's better now. I think the angulation is really important. Yeah.
Do you want to start with a smaller balloon? Because for
this is what we do.
Yeah.
Okay.
Off.
While exchanging the balloons, I will really commend Dr. Thierry Lefebvre and his team. I mean, going with a low frame rate and radiate to protect the team and himself from radiation. It's amazing they're using a caudal view and still you have relatively good view to see. So my message to my colleagues in here, I mean, don't forget radiation safety. If you can see it nicely with 7.5 frames per second, please do that. I truly advocate that whether you're doing a C2 intervention or non-C2 intervention, pay attention to radiation, but 7.5, we can see it very nicely. Thanks.
Yes,
2.5-12?
Ouais.
Semi-compliant? Ouais. So we'll use a smaller balloon, a 2.5. What is important also?
You have 10 minutes. Maybe you can finish with the kissing and give us also imaging.
Yeah, absolutely. Yeah, this is the plan. just to show you the OFDI at the end.
This is Dr. Hadi Abuhantaj from Jordan. I commend you on this wonderful case, Dr. Terry. I just wanted to, while you are exchanging the balloon, there was an elegant study coming from China, which was presented in the TCT 2020 about IVUS predictors looking at the ostium of the circ when you're doing distal left main bifurcating lesion. They showed elegantly that if you do IVUS, you pull back from the circ towards the left main, and you find layered atheroma, layered plaques, combined with minimal luminal cross-sectional area of 3.9 millimeters square or less, that will predict almost 70% plus that you will need a bailout stent for your provisional stenting, and you will end up with 2 stents at the end. So it's a kind of elegant way when you look at it, because the circ remains the Achilles heel of this distal bifurcation of the left main, to know, because the bailout happens, in the Excel study, it was 22%, and in the DK crush, it was about 47%. So it's something which we might look into as a routine practice, so that you don't do provisional when you have those criteria, because you will know mostly you will end up with 2 stenting.
Thank you
very much.
Thank you. So Terry, you did anchoring of the...
Yeah, so we use anchoring balloon in the LAD just to be able to cross. And I think the main problem is the angulation between circ and
because
an LAD. But now with the 2.5, I think we have enough space to use the 3.5 non-compliant. On va prendre le 3.5.
Le 4. Ouais.
Le 4, pardon.
It will be interesting to see the expansion of the stent in that ostial LED with the where you did the most of the shockwave pulses.
Yeah, absolutely. So after the kiss, we'll do FDI to show you that.
Question, Dr. Moteri?
Yes, Dr. Hani.
Yes, thank you. Dr. Lefebvre, I just want to ask a question. I'm Henry Raghi from Cairo. Do you believe that the trauma of a balloon, which is a PTCA, on the proximal circumflex is worse as far as restenosis is concerned, or the imagined eddy currents on a
it's a good question, but in fact, it's not really a trauma. We just opened the struts. Yeah, you can start. So we always do asymmetric expansion. So first, the circ, there is no stent. And then the
LED, yeah. I mean, that's a great question. This brings also the similar word. Can you use?
Yeah, we don't think it's a trauma because we do this technique. I think we need a randomized study. We are waiting for this. I think it's very important. We have done some studies, but it was not randomized, showing that at long term, we have good result in the side branch after kissing bone inflation, and it does not promote restenosis. So it's not damage, just opening the strut toward the big branch.
Yeah, I always open the struts for easier access in case I get restenosis. I totally agree with opening the struts, but I don't agree with opening them based on an imaginary eddy current thing.
Okay, so now we have done the keys. Maybe we can do an angio and the FDI, Thomas? Yes. Yeah. So maybe which kind of, I think okay. C'est bon?
Ok.
Ok, test. Au ciné. Vas-y. Ok. So as it was said by Thomas, we don't see really
well
the osteum of the circ. In any view, we try many views before being live. In fact, there is no good view. Okay, so now we have a nice size of the left main. We have good result in the LAD, and we'll do the OFDI. What is important when you have a relatively long procedure like that is to do ACT. So we are doing always ACT when we do a PCI, and in this case we start with a 3.7, 375. L'ACT, vas-y. ACT. Yeah, 386 ACT at the beginning of the procedure. So now we are probably close to 300, 320. So it's okay. But if you start with 250 at the end, you will be close to 200 or less, and then some risk of thrombosis.
What's your DABT strategy for your patients there?
The patient is already on DAPT after the disobstruction of the CTO of the right. So I think we will continue for probably 6 months. I think we don't need a long.
It's left main or other.
Yeah, I think it's enough. There is a lot of data about the duration of DAPT.
Okay.
About left main, and I think.
On est bon sur les. On va se faire un 5.
On se met à 5, hein, ouais. And I think we have, we don't need to have a very long double antiplatelet treatment.
Sur le, sur le.
Of course, in this case, the patient is a low risk of bleeding. Is 50, so we can prolong up to 1 year. But I think in this case, 6 months will be enough.
Any other opinion from the panelists about the duration of DABT? Dr. Horst?
Well, in left main, I tend to give it longer unless the patient has bleeding with so a year.
On va la refaire, elle est pas belle.
Tout est sélectif. Ouais.
Fais un petit test, Sarah? Non.
Yeah, we'll do it again because the quality was not optimal.
Un petit test à nouveau? Ok, on va descendre un petit peu.
On va faire 5,5.
Un petit test à nouveau, Sarah? Non, ça va.
Toi, 5,5. Ok.
Can you show us the of the arm?
Yeah, we'll do another pullback because the quality was not optimal. Pour toi?
Ok, on peut injecter.
Okay.
So I see some malposition
I agree.
During the pullback. So we'll see. So that this is the all stent. So this is the proximal.
Oh, yes.
And we see that there is so the apposition within the left main seems very nice, as you can see now. But there was a really malposition.
LAD, huh?
Yeah. Sure.
And no, in fact, it's a polygon of confluence, which is not fully opposed. Maybe you can pull back, go back. Sophie, vas-y, recule. Vas-y, continue.
So this is the old stents.
Okay, so this is a bifurcation between LAD and circ. And then when we go back, vas-y, recule. Okay, so now you see that stent is not fully opposed. Pull back. Okay. So we'll have to do another kiss at higher pressure, I think. Yeah.
And the proximal LAD also, right?
Yes.
Yes.
So this is the importance of imaging. When you have imaging, I mean, the angio can show you that nice result, but once you put your probe there, you will see, some struts, and this is very important. It can translate into, MIs and thrombosis.
Yeah, and also the duration of inflation, of course, in the left main will not do 30 seconds inflation. So it's very important not to hesitate to do several inflation, because it was tested in Japan in the bench, and they showed that if you do 3 times a kissing of 20 seconds is better than 1 time of 30 seconds, for example. So okay, I think this is LED. So, but we need also the circ, yes.
We always tend in the left main BCI to do, a quick inflation deflation, because when we think that, longer inflation might compromise the patient hemodynamics.
Je vais prendre un ballon de 4-9 pour refaire le kissing, si j'ai peur de pas.
Certainly, it depends on the full arteries of the coronaries, whether the patient has a little reserve or more. Sometimes you have to be quick, inflate and deflate.
Yeah.
My question was, if I'm not wrong, was it a 3-5 stent placed, the Megatron? Is it right? But the kissing was a 3 balloon in the LED placed.
No,
correct me if I was wrong.
3-5 in the LED and 4
LED. Yeah, but why
3-5?
I have placed a 3-5 stent? That is something I need to maybe Lefebvre can answer this. Is it
of course
undersizing, or is it because of iris image? Because I placed already a 3-5 stent, and that's maybe a reason why the kissing was not optimal here for the ostial LED.
Yes,
thank you.
Yeah. But in fact, the balloon was a 3.5. So 3.5, 3.5 in the LED and 4.0 in the circ.
Thank you.
So we'll do it again.
What balloon you are choosing now?
So SEM is 3.5. And I think what we can do, Thomas, at the end is to do a pot at the polygon of confluence at the end.
Yeah.
Okay, so this is a circ. So the 4.0. And this is a balloon of the LED. Yeah, okay. Okay, we can inflate here.
Wait, I have to remove a little bit the.
Yeah, but just inflate the
LED.
LED, yeah, just to have a free balloon. This is this one?
No. LED is here.
So how many atmosphere you went up?
So this is a 3.5.
I think you can go up to 16 or 18.
Okay. So it's a non-compliant. So we the 16 3.5 16 is 3.6, so it's non-compliant. Okay, it's okay, Thomas? Yeah, okay. And now Thomas will position.
2 minutes.
Okay, so Thomas will do pull back, the balloon of the circ just to open the strut correctly, and maybe pull back also. Yeah, okay, perfect. I think positioning looks very good. Okay.
So LED first.
Okay. And now we do the kiss with 4.0 non-compliant in the circ.
Okay.
You see, tolerance of the patient is good. Est-ce qu'on peut montrer le CG, s'il vous plaît, en régie? Okay. So you see, EKG is okay, pressure is okay. So we have time. Of course, now we deflate. Okay. Okay, and so because we have only 2 minutes remaining, so we'll do
final angio.
A final angio, absolutely.
Yeah.
And then off live, we will do again no FDI.
Absolutely,
huh?
Absolutely.
Are you planning to do report finally at the end?
Probably, yes. Just to be sure that we have a nice a position proximal to the polygon of confluence. Ok, on va faire l'angio. Ok. Vas-y. Ah. Now we have some difficulty to have a good angiogram. So I increase, okay, so it looks good. What do you think?
Good. Looks very good.
Okay.
Any work from your side, Terry?
Yes, so we just, what we will do is to do some pot proximal to the polygon of confluence, just to have full apposition of the stent at this level.
Yeah.
And I think it will be a nice result. Yeah.
So thank you very much. Thank you, Terry.
Thank you.
Thank you.
Thank you. It was a pleasure for us too.
And hopefully we'll see you in the future.
Thank you.
Thank you very
Bye-bye.
much.